So what is muscular dystrophy? It's a progressive neuromuscular disease characterized by progressive weakness, muscle atrophy, contracture, deformity, and progressive disability. Physical therapy is critical in this population to prevent complications, for the preservation of function, and for management of issues concerning quality of life. The role of the physical therapist for this population is to assist in identification and amelioration of impairments, to promote activity and the participation in patients, and to take a family-centered approach at setting reasonable goals. Below is a list of criteria that, according to the Guide for PT Practice, must be fully examined in the population of muscle dystrophy. Muscular dystrophy has a genetic origin. Its pathophysiology is that it's a progressive loss of contractility of the muscles caused by destruction of myofibrils. It varies in the rates of progression among individuals. The diagnosis of muscular dystrophy is confirmed by examination and laboratory procedures, including electromyography, muscle biopsy, DNA analysis, and assay of enzyme levels from the blood. It can be classified, after being diagnosed, by the mode of inheritance, the age of onset, the rate of the progression, localization of involvement, muscle morphologic changes, and the presence of genetic markers. The primary impairments are insidious weakness, and in congenital muscular dystrophy, contractures are also a primary impairment and are present at birth. Secondary impairments include development of contractures, postural malalignment, decreased respiratory capacity, fatigue, and obesity. Duchenne's muscular dystrophy is a dystrophin-associated protein and muscular dystrophy. It's the most common X-linked disorder. You'll see it 1 in every 3,500 male births and 3 in every 100,000 in the general population. It's marked by muscle cell destruction caused by an abnormal or missing dystrophin and its effect on the cell membrane. Medical management can include long-term steroid use, which has shown improved outcomes, and use of creatine has also shown improved muscle strength and endurance. Surgical management is focused on controlling lower extremity contractures, also surgery with orthotics to prolong ambulation, and spinal stabilization surgeries for cases where scoliosis is developed. Some impairments, activity limitations, and participation restrictions include pseudohypertrophy, or the infiltration of fats and connective tissue, have been found to affect the calves, deltoids, quadriceps, or forearm extensors. Like the name pseudohypertrophy, this results in the muscle looking bigger than it normally is, but not from increased muscle tissue. Muscle strength is decreased as noted by MMT. There are no limitations in range of motion before the age of 5 usually, but there will be mild tightness found in the gastric soleus and TFL. And there will be an increased lordotic posture with mild scapular winging noted.
Infancy to preschool age. There are no significant impairments, activity limitations, or participation restrictions typically observed during this age. It's reported that half of the children fail to walk until 18 months, and this rarely leads to the diagnosis of muscular dystrophy later in life. The mean age of the diagnosis is 5 years old. Early school age. The initial limitations occur by age 5 and tend to include clumsiness, falling, and ability to keep up with peers, especially while playing. Stair climbing and arising from standing from the floor become increasingly difficult at this age and signal the first significant functional limitation by age 6 to 8 years old. There are progressive changes in gait pattern, which include deviations in an increased base of support, pronounced lateral trunk sway, toe walking, and retraction of shoulders with lack of reciprocal arm swing. Falls become increasingly frequent in ages 8 to 10. This is due to the weakness of the iliopsoas muscle and complaints of fatigue while walking. Also, a restrictive pattern of pulmonary impairment and progressive decline in maximal vital capacity become increasingly evident. Examination consideration. The assessment tool chosen will vary depending on the diagnosis. Some functional assessment tools to consider include pediatric evaluation of disability inventory, school function assessment, Edgen classification scale, or Barthel index. Muscle weakness is apparent in the school-age child by age 6 to 8 and should be objectively measured. A clinical estimate of respiratory function can be obtained through measurement of respiratory rate and chest wall expansions. Also noting the child's ability to cough and clear secretions is important. Physical therapy usually begins when initially diagnosed at 3 to 5 years. The goals include providing family support, education, obtaining a baseline data on muscle strength and range of motion, and monitoring muscle weakness that may lead to activity limitations and participation restrictions later in life. Intervention considerations. During this age, overexertion and mobilization are detrimental. Prescribing a submaximal exercise program early has shown to have beneficial effects. Significant muscle weakness is not seen in the early stage of the disease, and the use of an exercise program may be burdensome to the child and family. If exercise is administered early, it's important to focus on the abdominals, hip extensors and abductors, and knee extensor groups. Intervention considerations continued. Some recommended exercises to consider include cycling, swimming, standing and walking at least for 2 to 3 hours a day, and breathing exercises to increase respiratory function. Exercises to avoid consist of resistive exercises and eccentric exercise. Additional recommended treatment includes electric stim, range of motion, stretching, or positioning for contractures, and the dosage is 1 to 2 times per day for 10 to 20 minutes for 30 to 60 second holds. Range of motion programs can supplement as part of the physical education program at the child's school. It's important to check the spine for scoliosis and posture analysis. Statistics show that 68% to 90% in boys with muscular dystrophy have the onset after cessation of standing at 12 years old. Falls and complaints of fatigue while walking become increasingly more frequent during ages 8 to 10. Motorized scooters and powered wheelchairs should be considered as a means of transportation as well. Adolescent period. Significant progression during the adolescent period results from the combination of muscle weakness and development of contractures. Walking is lost as a means of mobility and increasing difficulty with transfers. Manual wheelchair and powered mobility is necessary at this age for a means of transportation. Muscle weakness and contractures is especially pronounced in trunk and hip musculature. Examples include hip flexors, tensor fasciae lata, and gastrocnemius soleus. Walking becomes increasingly difficult as well until cessations at 10 to 12 years old. Knee extension lag in sitting and hip extension lag in prone are assessed to predict the cessation of independent walking during adolescence. Monitoring and managing contractures is very important during this period due to the children spending most of their time in a sitting position.
Continuation of standing or walking. Continuation of standing can be attained through standing frames, knee immobilizers, or KFOs. This will address the issue of decreased bone mineral density and the subsequent risk of fractures. Orthoses are also another option, however, they are not appropriate for everyone. These should be individual or personal decisions and should not be a therapeutic decision. Bracing has little long-term function or practical application, as these children will unfortunately eventually end up in wheelchairs. Listed on this slide are some prognostic factors that may indicate success with using orthoses. If orthoses are determined to be used, a KFO is your best option, as prescribed AFOs will not provide the knee stability required to avoid falls while walking. Assistive devices can also be helpful in these scenarios. Reciprocating or wheeled walkers are your best options. Standard walkers, crutches, or canes are seldom functional because of the degree of proximal shoulder girdle and upper extremity muscle weakness that is present. Many times, surgical interventions are also needed in conjunction with bracing as contractures progress. Indications include ankle plantar flexion contractures greater than 10 degrees, IT band contractures greater than 20 degrees, and hip and knee flexion contractures greater than 20 degrees but less than 45 degrees. The most common surgeries that you'll see are a subcutaneous tenotomy of the Achilles tendon and a fasciotomy of the IT band. Intensive post-op management programs are essential to minimize the effects of immobilization after these surgeries. As the disease progresses, standing pivot transfers eventually must be replaced by one or two person lifts and/or equipment. Transfers to and from the wheelchair, toilet, tub, car, and furniture will become dependent by ages 12 to 14. A hydraulic lift can be used for transfers to and from the wheelchair. These transfers become dependent due to knee and hip flexion contractures and pronounced weakness in the lower extremities. Hydraulic lifts are particularly useful in the cases when adolescents are large or obese, or when the caregiver can no longer safely perform a manual lift. Another thing to consider in patients that have muscular dystrophy is the development of scoliosis. The prevalence of scoliosis in this population is 50% between the ages of 12 and 15, and this prevalence increases to 90% by age 17. Utilizing the proper wheelchair accessories to ensure proper posturing is essential to help prevent the formation of scoliosis. Some of these accessories may include solid back and seat, lateral trunk supports, lumbar support, adductor pads, seat belts, chest pads, and footrests that support the ankle in a neutral position. You can also consider reclining back options to help prevent flexion contractures of the hip, and tilt in space reclining to relieve pressure ulcers. Maintaining the spine in a neutral or slightly extended position, trunk supports in the wheelchair, and spinal orthoses may help to slow the formation of scoliosis, but will not prevent it. Surgical intervention is recommended for the control of scoliosis via segmental spinal instrumentation with Luke rods or similar techniques. Due to the cessation of walking that occurs in late childhood, emphasis should switch from strengthening of the lower extremities to active and active assistive exercises for the upper extremities. Really focusing on having the adolescent assist as much as possible in ADLs is going to be essential at this time. Gentle stretching can also be utilized as discomfort in the joints begins to present. Limitations in shoulder flexion and abduction, elbow extension, forearm supination, and wrist extension are the most common. As these patients transition into adulthood, it marks a time of continued progression of disability with greater reliance on assistive technology and caregivers to function in their environment and carry out ADLs. At this time, use of a powered wheelchair is going to be necessary due to trunk and upper extremity weakness. As the disease heads towards its terminal stages, you're going to have to consider several things. These include requiring the use of a hydraulic or mechanical lift for transfers, assistance with ADLs, especially dressing, transfers, and bathing. The family is going to need to consider the use of assisted ventilation as respiratory involvement continues to progress, and a pressure relief schedule must be created in order to avoid skin breakdown. Respiratory function must become a priority as muscular dystrophy progresses. Respiratory failure or pulmonary infection is the major contributing factor to death in 75% of children with muscular dystrophy. Breathing exercises, postural drainage, or intermittent pressure breathing treatments should be included in management programs for these patients. A power-controlled bed to allow elevation of the head may also be a good option at this point. It will help to ease transfers, allow them to still do certain activities such as watch TV or participate in conversations. You should also consider the possibility of an airflow mattress for ease of bed mobility and decreased skin breakdown from pressure ulcers. The terminal stages of DMD are not the best time to have to be around these patients, but we still play a critical role. Respiratory insufficiency is a hallmark sign of the pre-terminal stage of DMD. Coordination of care with a respiratory therapist is going to be essential at this time. Severe O2 desaturation leading to a comatose state is evidence of the terminal stage. As a PT, we must be aware of these stages and how they progress so as to not make any inappropriate comments to the patient or their family members regarding prognosis. Many times, we will have to be the listening ear for that family regarding the pending crisis. Often, it is comfort to let the family know that the end may come while they go to sleep without waking. In addition, if support is needed outside of what you can provide, make sure to help aid in getting the person and or their family in contact with someone who can give them better help.
Becker muscular dystrophy. Becker muscular dystrophy closely resembles DMD. However, it has significantly slower progression with longevity into the 40s. It has the same impairments and weakness patterns, but is found to be less severe. Onset of symptoms is typically at 11 years, inability to walk at 27 years, and death at 42 years. This is compared to DMD, who are typically in wheelchairs by 11 years. A discriminator from DMD is frequent complaints of muscle cramping. Pseudohypertrophy of the calves and contractures can be present. Incidence of contractures, scoliosis, and skeletal deformities are lower in BMD and typically less severe. Cardiac involvement is common in BDM, specifically dilated cardiac myopathy. Goals and management similar to DMD. You especially want to have precautions of excessive fatigue and DOMS. Endurance training has often been found to be beneficial. Transition planning from school to assistance with living arrangements into adulthood is important. This is not often familiar to those with DMD because they typically do not have that long of a lifespan. Congenital muscular dystrophy. Congenital muscular dystrophy are muscle disorders with onset in utero or during the first year of life. They are typically characterized by congenital hypotonia, delayed motor development, and early onset of progressive weakness. There are 4 different types. The first one being congenital muscular dystrophy with CNS disease, Myrosin deficient congenital MD, integrin deficient congenital MD, and congenital MD with normal Myrosin. There are 3 types of congenital MD with CNS disease. I'm probably going to murder the names of those because they're kind of hard to pronounce, so you can read them. But typically, Myrosin deficient congenital MD is the most common, and you typically see those children never walk. And epilepsy and cardiac involvement is pretty common. And you also, with the Myrosin deficient congenital MD, can have partial Myrosin deficient, which is typically less severe because there's not as much involvement. Childhood onset facioscapulohumeral muscular dystrophy. This condition is rare, and it's typically an autosomal dominant or recessive disorder. Males and females are typically equally affected. You typically see signs and symptoms within the first 2 years, and disability is not usually quite noticeable until later in the first decade of life. Typically, during infancy and preschool age, you'll typically see muscle weakness in the face and the shoulder girdle. So you'll see like scapular abduction, and they won't be able to make facial expressions very well or be able to do things with their mouth, like eat and like swallow, and basically anything that involves like your facial muscles. And then also, they typically have independence in walking that is developed normally. But as you see, as they get older, they typically go more downhill. During the school age period, there's weakness is more generalized throughout the trunk, shoulder, and pelvic girdle musculature. Walking may be lost during the first decade. You see weakness in the hip extensors that progresses, and eventually they may have to go to like KFO or even power mobility. And so basically you see them starting to decline a little bit. As they get into adulthood, you're going to transition to planning for transition from educational environment, and that should be the goal of therapy. And also, it'd be beneficial to get assistance from vocational rehabilitation services. Congenital myotonic muscular dystrophy. This is a rare condition and eventually presents the severe clinical features of the adult onset myotonic muscular dystrophy diagnosis. This is an autosomal dominant condition. Those with congenital myotonic muscular dystrophy are almost always born to a parent with myotonic muscular dystrophy. You find in infancy that most develop independent walking, but they have severe weakness and partial paralysis of the diaphragm. Respiratory therapists and pulmonary care is needed as they are weaned from ventilation. Myotonia is also a symptom that develops around 3 to 5 years of age, which is a delay in relaxation after muscular contraction. This is a common symptom of those who have the adult condition. As they go into the school age, they're going to need more adaptive physical education activities. As they transition to adulthood, there's a natural progression of insidious weakness of distal, upper, and lower extremity musculature, and progressive increase in myotonia. The progression is similar to the adult disease, especially in the second decade of life. Emery-Dreifuss muscular dystrophy. Basically, there are 2 types. One is type 1, which is inherited as an X-linked recessive disorder, and they have absence of the protein emerin. And then the second type is an autosomal dominant or recessive disorder, and there's a defect on the protein lamin. Clinical features vary widely. Typically, you'll see contractures in the neck, elbow, and ankle, and also you'll see the humeroperoneal pattern of muscle weakness. PT management is limited in childhood because disability is not common. And then independent walking is typically maintained into adulthood, and typically they do range of motion programs for contracture prevention.